Hello, I will be giving a presentation entitled Treatment of Co-occurring Methamphetamine and Opioid Use Disorders. My name is Mariah Kalmin. I am an Assistant Research Professor at the Department of Family Medicine at UCLA. My background and training is in epidemiology, and I've been doing research for the past 15 years among persons who inject drugs and persons with HIV in trying to understand effective treatments for substance use disorders. I have no disclosures, no conflicts of interest. For today, there are three main learning objectives. First, we will demonstrate an understanding of the definition and epidemiology of methamphetamine use disorder, especially in the context of opioid co-use. And we will describe the neurobiology and development and maintenance of methamphetamine use disorder and how this relates to treatment outcomes. And then we'll review the evidence for advancements in pharmacotherapies and try to understand how that can be translated into clinical practice. So in terms of the epidemiology, this is the global picture of methamphetamine use as of 2019, and it is a global problem. We see the highest prevalence of methamphetamine use in Australia, Southeast Asia, parts of Northern and Western Europe, and the United States. In the US, the highest prevalence is observed in California, Texas, and a few other southern states. Now, we know that overdose deaths involving opioids have increased over the last 20 years. This slide shows that overdose deaths involving stimulants has also increased. And what's important to note is that the rate at which deaths involving stimulants has increased just as much as the rate at which deaths not involving stimulants has increased. And we also see the rate of deaths involving synthetic opioids such as fentanyl has increased. And these data go through 2017, but preliminary data from 2018 through 2020 also shows additional increases beyond these. So in the U.S., in the general population, the estimate of methamphetamine use is relatively low. It's less than 1%, but this doesn't tell us the whole picture. There have been dramatic rises of meth use among people who report using heroin and LSD. And so measuring methamphetamine use in the general population really gives us an unclear picture of the impact of methamphetamine use in the substance using communities. Likewise, the Reuter article pictured in the lower right found that heroin use cannot really be measured adequately using a general population survey because it doesn't get at the really vulnerable communities and how they use heroin and how they're at risk for overdose. So on the left side of the screen, you'll see that although over the last few years, the general estimate of methamphetamine use has remained consistent, we see significant increases among those using heroin and among those reporting LSD use. And what this means clinically is that there's been an increase in the prevalence of acute heart failure among those using stimulants, because as they use more, as we get more stimulant users and as they use more stimulants, we really see the effects of that in terms of acute heart failure. So we'll see heart failure related to cardiomyopathy, we'll see heart failure related to pulmonary arterial hypertension. And although those occurrences are relatively low in the general population, we're seeing close to 2% in stimulant users, which is very high compared to what it is in the general population. So now moving on to the neurobiology. First, before we jump into that, it's important to understand the physical and psychological effects of methamphetamine and how they relate to the function of specific subgroups who are particularly vulnerable to using methamphetamine and suffering undue consequences from it. So as far as the physical effects, we see increased heart rate, blood pressure, respiration, energy, and that corresponds to decreased sleep, decreased appetite. And then in terms of the psychological effects, we see increased confidence, increased sex drive, increased energy, and decrease in boredom and loneliness. So these effects are directly related to the subpopulations that are known to use methamphetamine. So shift workers use methamphetamine because they have to stay up at night. Similarly, people who are unstably housed often use methamphetamine at night to stay up, to stay safe. Gay men use methamphetamine to increase sex drive and increase pleasurability during sex. And rural and youth communities often use methamphetamine to alleviate boredom and to experiment with a stimulant. So it's important to remember that all behavior is brain, including behaviors like using stimulants. So this is a motivated behavior because it's motivated by physiological effects. And methamphetamine has direct effects on neurons in stimulating sustained dopamine release. And so behavioral and potential medication therapies affect neurotransmission. And so we are trying to target this neurotransmission with these therapies in hopes that in turn corresponds with behavioral modification. So there is a cycle with substance use and the brain and how the brain goes from one phase to the next in the presence of substances. So this figure describes that cycle, and what I really want to point out is the far right side that's highlighted by the red box. And so the brain cycles through various phases depending on how substances are used, but it's really that far right side where the brain is going through withdrawal. Specific to methamphetamine, we get this profound dysphoria, and that is what we hope to target with medications, with behavioral therapies. You also see that this profound dysphoria, as it's repeated, will lead to neuroadaptation. So the brain will actually change, and that will in turn change the response, the other responses, and sort of instead of going through this precipitated response and the normal response to drug, will sort of bypass that and go right into the binge intoxication. So with stimulant use, you do see this neuroadaptation that actually enhances the cycle, exacerbates it, and leads to the ill behaviors that we see as a result of methamphetamine use that's repeated over time. So I mentioned earlier this profoundly about dopamine. So methamphetamine inhibits dopamine reuptake, and it increases reverse transport of dopamine into the cleft. So what this means is that dopamine leaves the brain and it's inhibited in terms of returning to the brain. So you get this leaching of dopamine out of the brain, and that's part of what leads to this profound dysphoria once someone goes into methamphetamine withdrawal. And there is a dose-dependent effect. So low doses of methamphetamine and amphetamines are known to be therapeutic for different disorders, and they simply block dopamine transport. But high doses, in addition to blocking transport, also reverse transport. So it sort of exacerbates that leaching of dopamine out of the brain. So now moving on to pharmacotherapies, it's very important to note that currently there is no approved pharmacotherapy for any stimulants, including methamphetamine. There have been some promising primary methamphetamine use disorder medications. There is Mirtazapine, which is a known antidepressant medication that has been in the field for several years now and has recently shown some promise for treating methamphetamine use disorder. And there's also extended release Naltrexone plus high-dose Bupropion, which was explored in the ADAPT-2 trial, recently published, which also had a significant signal for reducing methamphetamine use among those with moderate to severe methamphetamine use disorder. And there are significant factors that increase the impact of these protocols. So first is that there's a lack of research among the polysubstance groups. So among those that use methamphetamine and opioids together, or methamphetamine and other stimulants together, we really don't understand how those drugs sort of interact and what treatments might be most effective in those groups. Secondly, some of these projects, the extended release Naltrexone plus Bupropion includes an injectable product. So this is the long-acting injectable Naltrexone, also known as Vivitrol. And the injectable products are really important because they eliminate adherence issues. So we've seen in other studies that the effect of these drugs are lessened when they're relied to take every day. So the injectable products alleviate that problem. So in looking at the Mirtazapine studies, there's been two main studies. Both have been done in a very similar population in San Francisco among men who have sex with men. The one on the left was the first one, and we saw a smaller trial of 30 individuals randomized to active condition Mirtazapine 30 milligrams per day, 30 people randomized to placebo. And we do see over the 12 weeks of that trial a steady decline in the percent of individuals testing positive for methamphetamine through urine drug screening. And there was a very strong signal at the end of 12 weeks. Similarly, in a replication trial that was done, the figure on the right, which was done in the very same population, intercity San Francisco, men who have sex with men, we see a drop over 12 weeks, and then we also see a continued drop over 24 weeks, same Mirtazapine 30 milligrams a day. So these are very important findings because Mirtazapine is a very safe medication. It's been approved as an antidepressant and has antidepressing properties, which is often a comorbid condition of people with methamphetamine use disorder. So these are very promising results. Next is the extended release injectable Naltrexone plus high-dose Bupropion. This was the ADAPT-2 trial that was recently published. This was an adaptive trial, so it had two phases, but the take-home point here is that across the two phases, there was an 11% difference in methamphetamine use among those who were randomized to the Naltrexone high-dose Bupropion group compared to placebo. So here, instead of showing percent positive urines, they actually show percent negative urines, and you see a steady increase in the percentage of study participants with methamphetamine negative urine drug screens over the course of the study. And you see that both in the first phase after the initial randomization, and you see that as well in the second phase when first stage non-responders are then re-randomized and have an opportunity to receive the Naltrexone Bupropion combination. You see those individuals also experience a significant increase in methamphetamine negative urines. We also see a fair amount of positive outcomes beyond just methamphetamine reduction. So we also see a decrease in methamphetamine craving, very significant decrease across both stages. for those who received the extended release naltrexone plus bupropion combination versus placebo. We saw a decrease in depressive symptoms as measured by the PHQ-9. And then we also see an increase in the subjective effects of functioning as measured by the treatment effectiveness assessment. So in summary, there has been about 25 years of research in trying to find effective medications for methamphetamine use disorder and other stimulant use disorders, and there are still nothing that's FDA approved. Mirtazapine has significant effects in men who have sex with men, which is particularly impressive, and the effects are in reduction in use, not abstinence. But so far, these effects are limited to a relatively small patient population, and we really need more trials to confirm that mirtazapine can be used for reducing methamphetamine use beyond men who have sex with men. The ADAPT-2 trial is a very strong trial with a strong signal for the extended release naltrexone plus high-dose bupropion combination. But one thing to note about this combination is that it cannot be used among individuals using opioids because the extended release naltrexone would precipitate withdrawal among anyone using opioids. And so we actually need an alternative pharmacotherapy for individuals who are co-using methamphetamine and opioids. Now, I would be remiss if I didn't mention the other treatments that have shown both efficacy and effectiveness in reducing methamphetamine use among those with methamphetamine use disorder. There's contingency management, which provides incentives for negative urine drug screens for methamphetamine. This is actually the most efficacious and effective treatment that we currently have, better than any medication or any other behavioral therapy. Motivational interviewing and cognitive behavioral therapy have also shown promise. There's the 12 steps approach, which is effective. It provides patients with structure and it provides them with social support, which is necessary as they go through treatment. And lastly, there's a harm reduction approach, which is effective in reducing mortality in this patient population. So what that involves is methods to use methamphetamine more safely. So if you have someone that's using methamphetamine by injecting it, motivating them to use it either orally or smoke it will result in potentially reduced use, reduced frequency, as well as reduced risk for overdose and death. So where do we go from here? And we really need to start to focus on the patients' populations that use multiple substances, either concurrently or sequentially, use them together to address the effects of certain drugs. So here we have individuals with methamphetamine use disorder, a portion of which use opioids. Now, they may have opioid use disorder, but there's a substantial proportion that probably don't have opioid use disorder, or at least they don't have a severe enough opioid use disorder to make them eligible for treatment for that opioid use disorder. Now, for moderate opioid use disorder, severe opioid use disorder, those individuals would qualify for medications such as methadone, which is a full opioid agonist, or buprenorphine, which is a partial opioid agonist. Those with mild opioid use disorder or opioid misuse would not qualify for buprenorphine or methadone. And so the next phase of research, we're really focusing on this co-using population. Now, there will be an upcoming study that's sponsored by NIDA through the Clinical Trials Network, and this study will be evaluating injectable buprenorphine versus placebo for participants with methamphetamine use disorder and co-occurring opioid use, there may be prescribed opioids, or opioid misuse. They may be either misusing their prescribed opioids or getting opioids from the street, or they might actually have mild opioid use disorder. So again, it would not qualify them for treatment, but it's still an issue for them. They still use opioids in addition to their methamphetamine. So for these participants, we will be screening them over a 21-day period and looking for 2 positive urine drug screens for methamphetamine. We will be looking for opioid use in at least 2 out of the last 30 days. And we'll be looking for a negative urine drug screen for buprenorphine, methadone, and opioids on the day of randomization, because we don't want them to have opioids in their system at that time, just in case we would precipitate withdrawal. There's about 250 participants in this patient population, or in the study rather, and they'll be randomized in a 1-to-1 ratio. And then any participants with moderate to severe opioid use disorder that are found during screening will be referred to treatment for that opioid use disorder. So they'll be referred to either a methadone clinic or another outpatient provider who can prescribe them buprenorphine. And one thing to note about the buprenorphine is that, as I mentioned before, it is a partial opioid agonist, but it's also a kappa antagonist. And that is why we think that it may be useful for treatment of methamphetamine use disorder, because it could potentially alleviate the dysphoria that's really prevalent and prominent when people who are using methamphetamine and have severe methamphetamine use disorder go into withdrawal. And in fact, there's been a few very preliminary studies who've looked at buprenorphine for methamphetamine use disorder and have seen a signal. There's been a small study, 2 small studies in Iran, and then there's been some pragmatic trials that have been using buprenorphine for opioid use disorder, but have found in their secondary analysis that it also reduced methamphetamine use for those individuals who were co-using opioids and methamphetamines at the start of the trial. So the objectives and outcomes of this study are to evaluate whether assignment to 12 weeks of outpatient injectable buprenorphine compared to 12 weeks of injectable placebo reduces methamphetamine use as measured by twice-weekly urine drug screens during the last 4 weeks of the study, so weeks 9 through 12. And secondarily, we are also going to look to see if injectable buprenorphine reduces alternate measures of methamphetamine use, so self-reported use, as well as use over the whole 12 weeks, as well as measures of opioid use and measures of methamphetamine and opioid co-use. And I just want to note that although we know that the methamphetamine using population and those with moderate and severe methamphetamine use disorder do use opioids, we really have a lack of understanding of the patterns of that use. There's very little data of an understanding of how methamphetamine and opioids are used together. Although we have some anecdotal information from providers and from people using methamphetamine and opioids, there are no systematic assessments. So this will give us some clarity on that. And then we'll be also exploring some other effects of methamphetamine and opioid use in terms of pain and mood instability and stress, infectious disease incidence and risk, measures of dysfunction, and measures of adverse events. So this study is a double-blind, placebo-controlled trial. So individuals randomized to the active condition will first get a sublingual buprenorphine film lead-in, and then on day 3, they will get injectable placebo, 300 milligrams, compared to placebo group who will get a placebo lead-in, and then they will get an injectable buprenorphine injection at day 3. and then they'll get injections every 4 weeks after that, so at weeks 5 and 9. And then there will also be a follow-up visit at week 16. So in terms of translating these results, the results that we already know and the results that we will hopefully, the positive results that we will hopefully see into practice, we have to understand what that entails and how to make these evidence-based treatments successful in the real-world setting. And what we need to make that happen is we need energetic champions in the field of substance use treatment who will place an emphasis on translating these medications and these practices into their clinics. They need to advocate for investments in training staff and changing workflows to make these medications work. And they also have to emphasize the whole person. So it's not just about the medication, but it's also about incorporating behavioral therapies, using other people just besides clinicians, so maybe behavioral specialists or peer recovery coaches, and continued engagement with staff and really understanding how these medications can be used effectively. There also needs to be a concentration on infrastructure support. So we need to get, since methamphetamine and opioids both affect populations that have a high degree of health disparities, we need to get these individuals insured, connected to housing and employment services. So one model that could give us some information and an example of how to structure our treatments for methamphetamine use disorder is the California Bridge. I serve as the PI and project director for the California Bridge, which is a clinical program that is funded by SAMHSA and other California state dollars in the state opioid response, and is continuing to be defunded by different funding mechanisms at the moment. And basically what it is a direct hospital payment that goes to hiring a substance use navigator. The substance use navigator serves as a liaison between the patient and the provider. So as patients come into emergency departments at these California hospitals, the substance use navigator is trained to understand and recognize potential signs and symptoms of opioid use disorder, and they can talk to the patient about starting medication, particularly buprenorphine. And then they also engage with the patient, understand their barriers and challenges to treatment, and connect them to other services, housing, employment. And then they follow up with that patient at 3 days, 7 days, and 30 days to see that they're to try to get them connected to outpatient care. If they return to the ED, they engage with them again at that point. And what we've seen is that this approach for treatment of opioid use disorder by interfacing with patients who are most severe and most dire and have the least likelihood of getting care in the outpatient setting is very effective. So these data show that over the first 14 months of the study, the California Bridge program across 52 hospitals identified over 12,000 patients with opioid use disorder, administered buprenorphine to over 7,000 of them. 5,400 also received a prescription for buprenorphine, and then about 4,800 actually reported engagement in an outpatient visit with a medication assistance treatment provider at 30 days. And so to hit that mark of about 40% who are engaged at 30 days is really profound, since this is a very vulnerable, high-risk population that goes to the ED for treatment, but also goes to the ED because they're suffering from intense withdrawal, and they also have, could go to the ED because they've had a prior overdose. Another aspect of the bridge that's very important is addressing disparities. And in this paper, we looked to see whether or not the California Bridge patient population, for those who are particularly disadvantaged, they have Medicaid insurance, they report unstable housing, they report methamphetamine use, whether or not they receive hospital-administered buprenorphine or they receive a prescription at discharge in the same way that people without those disparities. And we found that the bridge is actually doing a great job. And people who report unstable housing are actually more likely than those who are stably housed to receive hospital-administered buprenorphine during their ED visit. Those with Medicaid and methamphetamine use are equally as likely as those with others insurance and who do not report methamphetamine use, respectively. And the same thing with receiving a buprenorphine prescription at discharge. Those with Medicaid are more likely to get that prescription compared to those with other insurance types. And we see no difference in prescription at discharge for those with unstable housing or stable housing, those reporting methamphetamine use versus those not reporting methamphetamine use. So in closing, I'd like to say that methamphetamine use disorder is linked with a neural adaptation of addiction and targets for treatment. And there is no broadly effective approved medication for methamphetamine use disorder, but there is some promise for mirtazapine as well as the extended release naltrexone plus high-dose bupropion combination, and hopefully we will see some more evidence that buprenorphine can also be effective for reducing methamphetamine use disorder, and this will be particularly important in the population that uses methamphetamine and opioids together. And this raises the question as to whether it's time for methamphetamine use disorder treatment to start with medication. And as we see in the California Bridge, that model is particularly successful because it uses buprenorphine as a foundation and then also layers on other interventions such as the use of a substance use navigator, harm reduction, motivational interviewing to really foster that relationship between patients and providers and get them connected to outpatient care. And lastly, integrated treatments provide help to patients, and these include help that focuses on their biology, their behavior, and their culture, and these are all important elements to helping people reach and maintain goals regarding reducing their methamphetamine use so that we can minimize comorbidities, minimize overdose risk, and ultimately minimize mortality. I'd like to acknowledge several people. First, Dr. Steve Shoptaw, who's my mentor at UCLA, provided slides for this presentation, as well as the lead investigator of the Clinical Trials Network study that will be assessing the effectiveness of injectable buprenorphine on reduction of methamphetamine use. Likewise, my colleagues at the University of Texas Southwestern, who are also working with us on that CTN trial, and my colleagues of the California Bridge, the 4 directors who are instrumental in allowing us at UCLA to lead some of these research efforts and implementing some of our proposals. I'd like to thank you for listening to this presentation.